Good morning. I'm Professor Emmanuel Bachy. I'm working in Lyon, France, in the lymphoma department. And I will deal today with the question about how can we better treat patients with early relapsing follicular lymphoma patients. In 2020, there are still some challenges in follicular lymphoma patients. Some of them still die from their disease. It has been recently reported that lymphoma still remains the most common cause of death for follicular lymphoma patient. Histological transformation is another challenge for this patient. And more recently, we've seen that those patients relapsing during the first 2 years after being treated by immunochemotherapy have a quite poor survival with an estimated 40 to 50% overall survival after 5 years. There have been a huge number of prognostic factors that have been identified so far for the 2 last decades, either at the diagnosis of the follicular lymphoma or after the induction with immunochemotherapy for patients with high tumor burden lymphoma. And the progression of disease during either the first or the 2 first years after starting the treatment has appeared as a very poor prognosis marker. The earlier, in fact, you take the cutoff, after a progression, after 6 months, after 12 months, after 18 months, or after 24 months, the worse the prognosis is. And it has been nicely demonstrated based on the gallium data by John Seymour in a recent paper published in Haematology. How should we treat these patients with early relapsing disease, for instance, during the 2 first years after treatment, which is defined and commonly termed the POD24, progression of disease during the 2 first years after treatment? There is no, I would say, single answer to that question. There have been some papers published recently based on the lymphoma study group and the CIBMTR, showing that maybe for patients who are fit enough and young enough, maybe chemotherapy followed by autologous stem cell transplant might be the best option for this patient, with this treatment being associated with I would say, the best overall survival, if possible. For patients who cannot receive the autologous stem cell transplant, there are still different options. For patients that have been treated with bendamustine, for instance, at first line or by R-CHOP, you can switch the combination with R-CHOP or bendamustine. There have been some recent reports showing that R-square, lenalidomide plus rituximab, or lenalidomide plus obinutuzumab can be an option that is worth being tried in this patient. The GADOLIN trial showed that obinutuzumab plus bendamustine can provide a prolonged survival for this patient, and some interesting results have been published also with PI3 kinase inhibitors in that patient. So no single answer to that question. I think it really depends how fit and how young is the patient. If possible, maybe autologous stem cell transplant, but the main options, since there is no best treatment determined to date, might be to try to enroll this patient in clinical trial, and we are awaiting the results of what bispecific antibody or CAR T cell, what will be the results associated with this kind of therapy. Thank you for your attention.